Thank you very much to the Saudi Society for Rheumatology for inviting me to give this talk today. The title of my presentation is an update on clinical trials in SLE. These are my disclosures. So I'm going to give you an update in some clinical trials in lupus and sort of where that leaves us when we're thinking about how we manage patients with SLE. I'm going to focus, first of all, on B-cell targeted therapies, particularly anti-CD20 molecules and anti-BAFF or BLyS molecules. I'll also talk about some other mode of action agents such as baricitinib, voclosporin, and anifrolumab. So one of the issues in lupus is if you compare it with rheumatoid arthritis. So with rheumatoid arthritis since 2000, there's been a huge explosion of new treatments for rheumatoid arthritis that have been licensed and approved and are available for us to treat our patients with. In contrast, in lupus, there's a lot less drugs that have made it through to approval. Essentially, we've got belimumab, voclosporin, and anifrolumab, and voclosporin is only approved for lupus nephritis currently. What that means is that the treatment for our patients is inadequate. We depend a lot on corticosteroids and standard immunosuppressive agents. And that means we have a limited ability to completely control the disease. And as a result, we see patients developing irreversible damage over time. And that's not because we've not been trying. When you look at the immunology of lupus, our understanding of this has improved significantly over the past 20 years. We know that B cells are involved. We know that T cells, neutrophils, and dendritic cells are also involved, and many cytokines and signaling molecules are involved in the pathogenesis of lupus. Which means then that there are a lot of different treatments that have been tried. Many of these have fallen by the wayside and have not been approved or gone through to successful clinical trials. But we are beginning to make progress. So if you look at the trial outcomes recently, a number of treatments are now licensed, as I mentioned earlier. Some have stopped after phase 3 trials that have not shown a positive signal, and others are currently in later phase development. So when we think about anti-CD20 molecules, the first thing we think about is rituximab. And you'll remember the Explorer trial from 12 years ago now, which really showed no difference in the primary outcome in patients with lupus treated with rituximab compared to patients treated with background standard of care. And that was actually a big surprise because many of us see patients with lupus who respond very well to rituximab. And indeed, in our UK Biologics Register for lupus, we published data from the first 178 patients with 6 months of follow-up. And we found that over half of them had a demonstrable response to rituximab in the first 6 months after treatment. And indeed, if you look at patients with a major clinical response who got to a near remission state, about 20% of people develop that level of response at 6 months. There's no further development of rituximab in clinical trials in lupus, but obinutuzumab is a fully humanized molecule that has got a slightly different mode of action to rituximab in that it's less rapidly internalized through the anti-CD20 molecule, so therefore it's got a longer action on the cells. It's got increased Fc gamma receptor engagement and a different mode of cell killing. And the Nobility phase 2 trial, which is now being fully published, looked at patients with lupus nephritis who were given 1,000 milligrams on 2 occasions, 2 weeks apart at baseline and subsequently at 6 months. And they followed patients up to look at the primary endpoint, which was a complete renal response at week 52, defined as a PCR of less than 0.5, stable serum creatinine, and normalization of the urinary sediment. And what they found that while the primary endpoint of complete renal response was not met at 6 months, p-value of 0.115, the overall renal response, which was complete and partial renal response, favored obinutuzumab. And so this is now going forward into phase 3 trials. Belimumab is an anti-BAFF or anti-BLyS molecule, and the two pivotal trials, BLyS 52 and BLyS 76, showed that more patients treated with belimumab achieved an SRI-4 response at 12 months compared to patients treated with standard of care. That result was followed up by a further trial using subcutaneous belimumab that showed the same endpoint and the same outcome. So 61% of patients achieved an SRI-4 on subcutaneous belimumab compared to 48% with placebo. And in this trial, we also found a significant reduction in the likelihood of severe flares. Belimumab has now gone on to do a clinical trial in lupus nephritis. It was 104 weeks, so 2 years, and patients were given intravenous belimumab on top of standard of care or standard of care. The primary endpoint was a renal response at 2 years, urine PCR less than or equal to 0.7, a stable GFR, no use of rescue therapy, and a major secondary endpoint was a complete renal response with a more stringent proteinuria improvement. And in this large trial of 448 patients, both the primary renal response and complete renal response both favored belimumab over placebo. And in a secondary analysis, it's also recently been published, looking at deterioration in GFR over time. The deterioration in eGFR over time with belimumab was much less than what was seen in standard of care. So other mode of action agents. So the first one to think about is baricitinib. So baricitinib is a JAK1 and JAK2 inhibitor, and they had a successful phase 2 clinical trial. What you can see here is that the 4 milligram dose, remission of arthritis and or rash was achieved in 70% of patients compared to 56% of patients in placebo. The SRI-4, the flare rate, and achieving low disease activity also all favored baricitinib 4 milligrams. And if you look at the individual organ systems, skin disease activity measured by the CLASI score improved but was not significantly different between placebo and the 4 milligram dose. In contrast, the tender joint score was significantly improved in baricitinib compared to placebo, suggesting perhaps a better effect on the joints than on the skin. Voclosporin is a next generation calcineurin inhibitor. So it's off-target effects such as diabetes and hypertension, etc. And the first phase 2 trial looked at 2 different doses of voclosporin. And what they found was the low dose voclosporin improved, showed complete renal response at 24 weeks and 48 weeks, as did the high dose. There was really no difference between the low dose and the high dose from an efficacy point of view. And so therefore further trials were done with the low dose and voclosporin. In the phase 2 trial, there was actually higher mortality in the low dose group, 11% versus 1 to 2% in both placebo and high dose voclosporin. When they looked into this in more detail, it was partly because of the regions of the world in which this trial took place, where there were several patients in the low dose group who had significant infection. The Aurora 1 was the phase 3 trial, which used 23.7 milligrams BD. The primary endpoint in the Aurora trial was a renal response at 52 weeks, a UPCR of less than or equal to 0.5, which is very stringent, a stable eGFR, sustained low-dose steroids, so patients had to get down to 10 milligrams or less of prednisolone. And there was a very rapid early steroid taper in this trial, and no rescue medication was allowed. So what this trial found was, if you look at complete renal response at week 24 and week 52, This favored voclosporin, and a partial renal response with a less stringent definition also favored voclosporin at both 24 and 52 weeks. Anifrolumab is a drug that targets the interferon system, and it's an interferon receptor antagonist. And so therefore it downregulates the activity of type 1 interferons by blocking the receptor and subsequent signaling. The phase 3 TULIP trial program included two trials, TULIP 1 and TULIP 2, both very large trials, one with 450 and one with 360 patients. And they were followed up over a 48 to 52 week period. When you look at the interferon signature suppression, what you see is that pharmacodynamically the drug did what it was meant to do by significantly suppressing the interferon gene signature. The primary endpoint in the TULIP 1 trial was the SRI-4 response. And what we find here is that the SRI-4 was not met in the TULIP 1 trial. However, when we look at the reduction in the CLASI score, so the skin scores at 12 weeks, you can see a significant benefit in favor of anifrolumab. And if you look at the BICLA response, the BICLA is a BILAG scoring system based outcome measure. And again, it significantly favored anifrolumab. So while the TULIP 2 trial was still blinded and before they did any analysis, BICLA was then chosen as the primary endpoint for the TULIP 2 trial. And in this trial, the BICLA response favored anifrolumab over placebo. And again, you see the same thing with the CLASI score, that the CLASI score was significantly improved in anifrolumab patients compared to placebo. The SRI-4, incidentally, also favored anifrolumab in this trial. So this is the TULIP 2 BICLA data. And again, you can see an early separation in the BICLA responses that was sustained out to week 52. And if you look at the CLASI score, so the skin score, you can see a very early rapid improvement in the skin score that was sustained out to week 52. So to summarize, therefore, new treatments for lupus have been very slow to develop. But recently, we've had some very exciting data that suggests that we're beginning to make progress here. So several agents have now shown efficacy in randomized trials, belimumab in trials of lupus, as well as in trials of lupus nephritis. In lupus, and it's now been licensed in a number of countries, and it seems to have a significant effect on the skin, but probably and also on other organ systems. Baricitinib is no longer being developed because the phase 3 trials didn't consistently favor baricitinib. But within the phase 2 trial, there was a strong suggestion that joints were improved with baricitinib, and voclosporin has now shown benefit in lupus nephritis. The important thing from all of these trials is that most treatments seem to have an approximately 40 to 60% response rate. So they don't work in everybody. In fact, they work in half of the patients that we give these treatments to. So what that tells us, and what I think we're beginning to understand, is that lupus is a disease with different subsets, and different subsets may do very well with particular targeted therapy. So we now need to look at these trials, look at subset analyses, look at more detailed studies to develop robust ways to identify clinically relevant patient subsets. The other thing that we've learned from these trials is that combinations of therapies targeting different targets seem to be very effective. So in the belimumab lupus nephritis trials, patients were also given steroids, mycophenolate or cyclophosphamide on top of belimumab. And that combination therapy had a better outcome. So in the near future, we need to work to develop and validate precision medicine approaches in lupus. to understand organ-specific and or pathway-specific responses and develop newer attention. And I'm happy to take any questions in the panel discussion. Thank you.